Welcome everyone to DDU Cases Part 4. I get a bit sick of my own voice saying that, but today we'll have a bit of a pregnancy theme. There'll be, just practicing that Viva technique. It won't be as good as Yang's, I'm afraid, but we'll do our best. So I think those of you that are sitting again soon, please try and do some of the cases. I don't want to force you into it, but I think it is good practice. We'll start with just 2 point and shoot things if anyone's interested in having a little go at that. You've got a volunteer for this one. It's relatively straightforward. You can all do it as a group if you like. Oh, I haven't looped it, sorry, because I literally just popped this one into the talk. Any volunteers for what this shows?
Like a small, probably a PFO with bi-directional shunt.
Yeah. Nice one. It's a stretched PFO with predominant left to right shunt. Do you see how it's predominantly blue from the left atrium into the right atrium?
Yeah.
Yeah, but there is a little flash, I agree with you, right at the end, that little flash of right to left as well. But predominantly left to right, which is, I guess, more in keeping with one of those stretched PFOs. This patient had very high left atrial pressures, like chronically. Cool. All right. What does this show?
No one wants to have a go.
Yeah.
I mean,
What are we looking at? What type of Doppler?
So that's a pulse wave Doppler. No, that's a continuous wave Doppler.
Pulse wave, yeah.
That's pulse wave,
right.
is it?
Yeah.
Okay.
Yeah.
I like to say it's a VSD.
Yeah.
But,
yeah, nice. Yeah, it's a mean one. But yeah, the sonographers just put it across the VSD. So you've got obviously, a lot of flow above the baseline, which you would not expect to see in that view. And then probably mirror artifact below the baseline there, because it's a VSD with obviously left to right. And this is the 2D with color. Can you all see that? Sorry, hopefully the rest of these loops will play, guys, but I've just dropped these in because they're hot off the press. You all appreciate that VSD. It's a perimembranous VSD, and you can see it nicely in the short axis being just about the 11 o'clock position, which is fairly typical for a perimembranous VSD. Cool. All right, we'll get on with some cases. They're all quite difficult, I think, these cases. So, whoever wants to take it first. Hey, do you want to go? You seem to be on a roll.
Yep.
Yeah.
So 25-year-old who's 36 weeks pregnant, no past medical history, normal pregnancy but short of breath. She's edematous, mild hypotension, normal lactate, and bilateral pulmonary infiltrates. Okay. It's very abnormal echo for a woman in third trimester. There's a large left-sided pleural effusion, and I'd expect LV to be hyperdynamic, but LV function's impaired. So we're looking at anteroseptal and infralateral wall. I don't think there's a regional wall motion abnormality. I think it's global. LV's dilated and at least mildly impaired. Actually, I'd call it moderately impaired. LA also looks dilated. The RV outflow tract also appears enlarged. Yeah, so there's a posteriorly directed MR jet. And I think the mechanism is probably from dilation of the annulus. And in terms of in the short axis view at the papillary level. Again, I can't appreciate any obvious regional wall motion abnormality. I think it's globally but sort of mild to moderately impaired left ventricle. The RV, just on this image, short axis, I think that's probably a prominent trabeculation, but I like to look at it in other images.
What would you give your visual? What's your visual EF?
40%. Oh, okay. So again, subjectively sort of dilated, and I think moderately impaired left ventricle. No obvious. Actually, in this view, the apex looks there seems to be regional wall motion abnormality, especially in the apex, in the LV apex. There's that eccentric MR that we looked at earlier.
What walls are we looking at here? This one?
Yeah, so the infraseptum and the anterolateral wall.
Yeah. And this one?
So the inferior and anterior wall.
Yeah. Can you comment on the mitral regurgitation?
Yeah, sure. So it's posteriorly directed. Gosh, I mean, it's eccentric. The collar Doppler doesn't look all that significant, but the LV function is quite impaired. Again, I think in terms of the mechanism, I mean, it could be from dilation, as I initially said. It could be due to restricted movement of the posterior leaflet, but I don't think that's the case looking at the 2D image. So yeah, I think most likely from as a functional, sort of due to dilation.
Anything else to comment on in the fold
Other
change?
things, yeah, the RV, the TAPSI appears preserved. Yeah. And yeah, some prominent probably B lines in the far field. Yeah, so the biplane ejection fraction sort of confirms the subjective assessment. The VTI is, I mean, look, I think I could have measured that a bit better. Like it should technically be at the modal velocity. It's normal at 21 or 22, but I think it's because of the MR. Oh no, that's not true. So that doesn't really. So normal VTI with sort of moderately impaired LV function. If I sort of trace it a bit better at the modal velocities, there might be a bit of an over estimate.
Any other reason why it might be higher than you expect for the degree of
Yeah.
LV impairment or reduced ejection fraction?
It could be also from if you had sort of obstruction at the aortic valve level. I mean, LVOT, VTI would also be increased, but that's not the case here. So I'm not sure.
Okay, Hewan. What's your overall impression of what could be going on for this lady, and outline an initial management strategy?
Yeah. So, I mean, there are multiple differentials for sort of LV systolic impairment and mitral regurgitation in a pregnant woman. But I think the most likely diagnosis is a diagnosis of exclusion, but I'm worried about sort of peripartum cardiomyopathy, especially in the absence of previous cardiac risk factors. I mean, the initial management would be sort of resuscitation and investigation. So in terms of resuscitation, I think I've used diuretics in the first instance. And careful introduction of beta blockade, multidisciplinary management of obstetrics and cardiologists with expertise in obstetric cardiology. Yeah. Yeah, so I'll just stop there.
Good job. Well done. Let's just go through. So I thought you did well, very well. I think you got all the major things, and your initial management plan sounds very reasonable. And initial thoughts about what's going on. I really love that you said it's always a diagnosis of exclusion, because it absolutely is, and you need to think about other things.
Mm.
But let's just go through the echo pictures first. So yeah, sometimes they do give like X-rays and stuff just to give a little bit more context to the stem. But yeah, it looks congested, with I didn't keep the CT on, but she had bilateral effusions, which you can then see on the echo, with fluid in the fissures and sort of bat wing pulmonedema. I think you got all the major points: large left pleural effusion with a bit of collapsed lung in there, moderately impaired LV. It is mildly dilated, but it's not above 6 centimeters, I don't think, which is a bad prognostic marker if the end diastolic volume is more than 6. Um, the LA looks a little dilated. Usually in pregnancy here, you get sort of a balanced dilatation of all 4 chambers. So the LA
Oh,
does
of
look,
course.
so bigger than the right atrium. And you'll see that there's bowing of the intraatrial septum to the left with the effusions in the B line. So she's congested with raised left atrial pressure. I guess that's probably one of the things that you didn't mention, which they might press you for. But I didn't show you any diastology purposefully, but I think there's enough information to say that she has got raised LAP and she has got pulmonary edema. But you said that you would, diuresis, and obviously you're going to be a bit cautious with that because of placental flow and how dependent that is. I think you're right about the MR. It's functional. There's like reduced like tenting and reduced coaptation distance of the mitral leaflet, which is there's slightly restricted movement of the posterior leaflet, which is why I think the MR, you got that end to side coaptation, which is why the MR is posteriorly directed.
Mm.
It looks mild to moderate, I would say. I haven't shown you any of the things that you could comment on that with. Global moderate LV dysfunction. And then you got most things on this here one. You were obviously very comfy with the walls, the RV. The only thing I would have liked you to mention, especially in this context, to someone that's short of breath and things, is the intratracheal septum
Sure.
bowing across, fixed bowing to the right, which is a pretty good sign when you combine that with the lung features and the LV features too, of
Mm.
raised filling pressures. Um, but otherwise, you got that. I think it's globally down. What are the other things that you would look for? What are they particularly high risk for with peripartum cardiomyopathies, especially when
Um,
the apex is down like that? I haven't
yeah,
shown you all the pictures.
the thrombus.
Yeah. So I think that would be like, again, it would be probably on the mark sheet. Like if you mentioned that you'd want to interrogate the apex more off-axis imaging, really interrogate for a thrombus and consider giving um, contrast outside the setting of pregnant. Like sometimes it's not recommended actually in pregnancy, contrast affinity, but in some
Mm.
cases you do, and it's all about risk benefit. But yeah, it's not licensed for use in pregnancy. But you definitely want to do some off-axis imaging and, have a good look for a thrombus up in that apex. EF, I think your visual is good. I said about 40 as well with the visual EF. I don't know whether anyone had any other thoughts on the visual EF based on these. The Simpsons isn't perfect because I think it is a little bit foreshortened, but it's around 40% for the EF. I think her VTI is preserved at this stage. She hasn't got severe heart failure, but I think it's preserved because she's gone through her pregnancy and increased her blood volume, right? So her cardiac, like her stroke volume and blood volume has increased 40% or so in pregnancy. So she's already remodeled and got a higher blood volume. So even though her
Sure.
EF is down, she's got, more total volume, which is why her VTI is preserved. Another reason her one could have been, I haven't really shown you, could have been aortic regurgitation, which I didn't show you any of that.
Yeah,
But
of
that's
course. Yeah.
another, potential cause. The obstruction thing, I think, was a little bit off-piste because it doesn't, none of it kind of fits with that, but that's all
No.
right. That's, um, and so what usually happens to EF in pregnancy towards the end of pregnancy? Does it increase, stay the same, go down?
Um, I was gonna say it goes up, but maybe it's a bit of a trick question. Is it the LV dilates? So despite increase in contractility, it stays the same?
It stays about the same, your EF.
Okay.
Yeah, it even can dip a little bit towards the end of pregnancy. And your same for your like global longitudinal strain of your LV. Like it can usually stays about the same, but does start to maybe plateau off towards the end of the third trimester. Your E to A ratio tends to go up a little bit because it's obviously preload and afterload dependent. You're increasing your preload, you're reducing your afterload, so your EA ratio goes up. But your E to E prime tends to stay static. There's a little bit of mixed data on this, but there's a nice paper here, which is the BSE transthoracic assessment of the heart in pregnancy that goes through all of that. If you wanted to, it's worth reading because pregnancy stuff does come up in the written and the Viva exam, and it's a nice document. Then, yeah, possible peripartum cardiomyopathy. It's definitely a diagnosis of exclusion. She's in the right time frame, isn't she? So it usually happens towards the end of pregnancy. I think she was 35 weeks. Or in the postpartum period. I think most happen in the postpartum period, 66% within the first 5 months postpartum. The diagnosis is an EF less than 45%. They don't have to be dilated, but they can be. Bad prognostic markers in peripartum cardiomyopathy, EF, this is all in these documents, guys. So EF less than 30%, dilated, LV more than 6, and if there's RV involvement. Obviously, your management is going to be multidisciplinary. You're very worried about this patient. You're going to manage her proportionately to the degree of heart failure. Like if she's got cardiogenic shock, you're going to manage her, for a cardiogenic shock. If she's in heart failure and congested but still warm at the edges, and which she was, and you can probably tell that from her VTI, then you're going to, cautiously diurese, and as you said, a bit of a borderline blood pressure, but start to introduce heart failure things that are safe in pregnancy. And then they mention in the new guidelines actually the use of bromocriptine, so prolactin antagonist, for peripartum cardiomyopathy. I think it reduces the severity of the heart failure. And if it's not that severe, they give it for like a week. And if it's more severe, you can continue it for 6 weeks. But you need to give anticoagulation because it's prothrombotic, bromocriptine. But this is obviously all specialized stuff, and they wouldn't expect you to talk about this in the Viva, but just out of interest. And yeah, their prognosis is not insignificant. Some of them can have ongoing heart failure, and they definitely need follow-up. And then sadly, like about 50, up to 50% of them will get it again during subsequent pregnancy. So you need to sort of counsel them for that. All right, second case. Do we have it? Well done, Hewan. You would have passed that Viva. It was good.
Thanks.
Any other volunteers? Who do we have? I don't want to pick on anyone, but you don't have to volunteer. I've got Rosie beside me, so
I can go ahead.
come on, Rosie. Is there anyone else sitting their exam soon? I can't see you all. I'm so sorry. Hang on.
Rishi here. I'm online.
Oh, Rishi. Rishi. Hang on, let me check. Oh no, this is good, Rishi. You've seen the third one, so this one's a good one for you to do.
Okay.
All right. Thank you, Rishi.
No problem. 42-year-old lady, G6, para 5, nausea, dizzy, GCS drop on mobilizing, met call, ECG T wave inversions laterally, troponins of 759, impression of non-STEMI, lots of babies in the past. Okay. So personal long axis view, the most obvious feature is severely reduced LV function. Commenting on the LV, so the LV size appears subjectively enlarged. LV function appears severely impaired. There appears to be preserved anteroseptal left thickening of the LV walls, and infralaterally the base of the infralateral wall appears down. Mild dilatation of the RVOT, aortic root, and appears normal. LA size appears moderately enlarged. There appears to be prominent V lines on the far field suggestive of interstitial edema. Looking at short axis views, subjectively there appears to be LV function appears to be around 40 to 45%, with good coaptation of the mitral valves. RV size appears mildly enlarged. There appears to be no evidence of any pressure or volume overload. And on going towards the base, again, there appears to be reduced LV function. So seems to be preserved, LV function seems to be preserved at the base, but going towards the mid and towards the apex, probably a bit down.
Rishi, what walls is my cursor on here?
So that is the anterior wall there. Yeah.
I'm just moving
anterior
it around.
Anteroceptal wall, yeah, that region.
Yeah, but this one here.
So that would be the anterolateral, inferolateral, inferior and inferoseptal. So there appears to be definitely reduced hypokinesia in the inferoseptal and the inferolateral and anterolateral region, which was fitting with the lateral ischemia picture of what was shown earlier. Commenting at the 4-chamber views, these are focused views looking at LV function and thickening of the walls. The anterolateral wall appears to be edematous or thickened subjectively compared to the inferoseptal walls. Inferoseptal wall appears to be thinned. There appears to be reduced thickening or contractility at the base compared to the apex. And the findings are similar on the 2-chamber views. So looking at the anterior and the inferior walls, they are reduced contractility at the base compared to the mid or apex, and same with the 3-chamber view as well. Looking at the anteroseptal and inferolateral walls, reduced thickening towards the base of the inferoseptal. I can't see properly the apex of the inferolateral wall at this stage.
Okay. Taking out any walls, do you think the apex is normal or hypokinetic or hyperkinetic or hypokinetic?
So apex seems to be hyperkinetic compared to the rest of the base and the mid of the.
What do you think of the mid ventricle across all walls?
So mid ventricle appears to be hypocontractile, so hypokinetic, I would say.
And how about the base of the heart?
So base is probably hypokinetic as well. I mean, mid appears to hypokinetic or to akinetic, but base appears to be hypokinetic.
What's this looking at, Rishi?
So we are looking at the papillary muscles. We are looking from down below, from LV towards the LA. And this is a 3D view, looking at basically the papillary, the cross-section short axis view of the LV across the pap muscles, which shows that the septum appears to be contracting well, but the lateral wall is completely akinetic in this view.
What
And
does
this is
show?
The strain analysis, which shows preserved contractility at the apex, but the anterior and the inferior and infralateral wall appears to be reduced or hypokinetic compared to the apex. The inferoseptal and the anteroceptal walls appear to be they have reduced contractility as well. And
what's your overall impression of what's going on and your initial management for this patient, Rishi?
So the regional wall motions do not fit with any particular coronary arteries. There appears to be potentially a a demand ischemia or a Takotsubo picture, which is going on, which can explain what is going on at this stage: pregnancy, raised troponins, ST elevations. But that is a diagnosis of exclusion after ruling out coronary ischemia. So at this stage, I will definitely cover her with systemic anticoagulation and antiplatelets while involving the cardiology team to discuss regarding a feasibility of a coronary angiogram to rule out obstructive coronary artery disease and supportive management.
So she went for her angiogram and she had normal coronaries. You have to take my word for it. I don't know if you're anything like me, but that's the right and the left main insert and stuff.
LCX, RCA, they're all appears to be quite patent, and the LV gram appears to be.
Yeah, what do you think about the LV-gram?
LV gram appears to be
interesting.
Normal to mildly reduced, I would say.
Yeah, but the pattern.
Oh, pattern. Yeah, again, the mid region is where it is reduced, and that can happen in Takotsubos as well, based on the distribution of the beta-2 receptors. It is kind of a reverse Takotsubo pattern, which can be seen in these cases.
Nice, Rishi. And that's the end of the case. And well done. I thought you did very well. Does anyone have anything to add about anything that we went through? I just go through. I don't have much to add. I think you said everything, Rishi, from memory. If anyone's got anything they want to say or clarify, please just shout out. But yeah, the basal infralateral segment is normal. This is akinetic. This is akinetic. This is hypokinetic. The basal anteroseptal region. So yeah, definitely basal sparing, but these mid segments, I'm not sure you were specific about that. And I could have pushed you harder and said I could have put my pointer here and said, what is that akinetic hypokinetic? And they might do that in the exam actually. And then, what's this one? Hypo, akinetic, this one. So I probably could have pushed you just to be a bit more clear on that, but that was my bad, not you. You got everything, the B lines, the rest of it, the RV is involved as well. That's down. RVOT. And then, this was trying to just show that the base looks relatively preserved, but the mid-ventricle looks, severely hypokinetic / akinetic. It looks kind of globally reduced, isn't it? But no septal dyskinesia to suggest any RV overload. I thought you did this well. I think probably you could commit to using like the language, like the being more specific with your language, like using normal, hypokinetic, akinetic, and just make a call. It's subjective. It's the hardest thing in echo is regional wall changes, and the images are not perfect, and they're not going to be perfect in the exam either, unless you get a contrast study. But so really just go through them and just say, the basal anterolateral wall looks normal, the rest of it looks akinetic, the apex looks normal, the basal infraseptal region looks normal to hypokinetic, but the rest of the wall looks akinetic, etc., and just go through the rest of it like that. You did say that this looks edematous, the anterolateral wall, which obviously takes you down a slightly different path, doesn't it, of like myocarditis and all that stuff. I'm not sure it does, Rishi. And also you've had the short axis views to just look at that as well. It doesn't, I don't know, it doesn't look like a terribly, it's it doesn't look like one of those sort of edematous myocarditis pictures, but that's fine. That's not it's a very small point. And sometimes the walls can look thin in a 4-chamber, especially if you're not quite seeing the endocardial border definition properly. So always really key, you need orthogonal views. Like you can't comment on LV function without seeing it in the short axis as well. You can get a feel, but you can make big mistakes if you just view in one plane and not orthogonal planes. And you can see from the views here that the walls are not terribly thinned, but they're just akinetic in the midsection. And that's all this is shown. They've just got the cursor through the mid ventricle and it just showing it's akinetic. This is the same as a normal plaques through the pap muscle level. I just think the 3D shows it beautifully. That is, completely akinetic in that region, and the strain does too. Although you could argue that it's not perfect, but there's certainly preferential sparing of the apex, and maybe the base is a bit better than the mid, and it's mainly that sort of mid variant. What else would give you this cherry on top appearance? What other pathology? Yeah, nice. But obviously the heart would look very different. That was all good. So yeah, reverse Takotsubo, mid ventricle variant. Just so Takotsubo is associated with a fairly poor prognosis. I don't think we quite appreciate that a lot of the time. You say, oh, they've got normal coronaries, it's fine, but in fact their MACE events are similar to having an acute coronary event. There's Mayo criteria for Takotsubo cardiomyopathy, which is, as you describe, really LV regional walls that are extending beyond a single coronary segment, that they haven't got any significant coronary stenosis more than 50%. They do tend to have ECG changes, and they do tend to have some troponin leak, and you have to rule out other things like myocarditis and other things. And yeah, the management is very much supportive. They definitely need follow-up, and there's some features that make prognosis worse, which would be the ones that you would probably think about in terms of it's more severe, the worse the prognosis. If they've got cardiogenic shock, obviously that's poor prognosis. Those that don't recover as quickly, and apparently those that have physical triggers tend to do worse.
Okay.
All right, you've seen this case, Rishi, so I might ask for another volunteer if that's okay.
Can I go, Emma? It's Rob.
Hi, Rob. Yeah, you ready?
Yeah, sure.
Yeah, I haven't given much of a stem for this one, Rob. Sorry.
I've got a pregnancy theme for this one, though. Hey?
Yeah. It's all pregnancy this week.
All right. So this is a deep parasternal long axis view. To the right of the image, you can see evidence of some B lines suggestive of congestion. Looking at the ventricle, so the anterior septal inferior lateral walls of the LV appear to be normal in function so far. The concerning feature is the aortic valve and potentially even the aortic root. I'd like to look at that in a more focused view with reduced depth, etc. But it appears like there's an abnormality there with both of the leaflets potentially just being cut off axis or maybe even flailing into the ventricle. Like I said, I'd like to see that in more detail, zoomed in, etc. Interesting. So there's an eccentric regurgitant jet to the superior portion of the screen, so sort of tracking along the intraventricular septum. It's very small, so I'd need to see that in other views to comment on where it's coming from. And then there's some flow acceleration across the valve. So again, I'd like to see the valve in orthogonal views and interrogate it properly. Not much else to comment on here. I can only see portion of the left atrium, but there's no significant mitral regurgitation that I can see.
Any other thing about the colour flow, Rob, in the aortic valve, apart from the regurgitation that you've mentioned?
Yeah, so there's turbulent flow, supravalvular turbulent flow, which is not usual. I haven't seen any 2D abnormality yet, but I'd be concerned about if there's a supravalvular lesion, like a membrane or something that's causing that. But it seems to be superior to the aortic valve. So this is so this is M mode through the aortic valve. Just checking that it's been cut through on the appropriate axis. You can see that there's good opening of that aortic valve, but the sort of the direction in which it's opening is a bit abnormal, and there's increased leaflet thickening. So I'd be concerned if there's a valvular abnormality. You could see a picture like this in bicuspid aortic valve. Yeah, okay. So I think we've confirmed that the patient has a bicuspid aortic valve. The opening shape is not typical for a normal trileaflet valve. So just interrogating that further. I think it's, thank you. It looks like a true bicuspid when you slow it down. So where you would expect to see the non-coronary and the right coronary cusp, there's no, I guess, annular connection at the 10 o'clock position. So to me, it looks like a true bicuspid aortic valve. So this is apical 4-chamber view. So no standout. That's all right. So no standout. That's all right. No standout features. So I'll just go through systematically. The inferior septal and anterior lateral walls, what I can see, are functioning normally. The mitral valve appears to be normal structure. The left atrium and right atrium of normal size, and the RV systolic function appears preserved. So this is we've got some tissue Doppler of the septal and lateral annulus, and then a mitral valve inflow. So just starting at the septal and lateral annulus. Septal is on the borderline for normal in terms of E prime velocities. Less than 7 is abnormal, and lateral is in the normal range. So no suggestion of impaired relaxation there. And then looking at the inflow velocity, so it's in the normal range, deceleration time is okay, and the EA ratio is normal. So with normal left atrial size, normal relaxation velocities, and normal inflow and velocities and ratio, I'd suggest that there's no suggestion here of raised left atrial pressure. This is pulse Doppler through the pulmonary vein, so the probably right upper pulmonary vein, and the S wave and D wave at normal ratio, and the AR velocity, it's on the cusp. So let me, P vein A, yep. So that's on the cusp. If it's been measured correctly, greater than 35 is considered abnormal. We haven't measured the AR duration. So this is, so we've got, color through that LVOT aortic valve. And again, we can see that there's turbulent flow, which appears to be coming supravalvular. And we've already demonstrated on 2D that despite there being a bicuspid aortic valve, the valve is opening without restriction. So I suspect it is supravalvular, this color, this flow acceleration. And then we've done a continuous wave Doppler through that with the velocity being greater than 3 meters per second. And so that's in keeping with increased velocities and a mean gradient that's 23. So I'm concerned that there's something supravalvular that's causing those increased velocities. Just, would you mind playing the color again, Emma? There's no significant associated aortic regurgitation to explain the increased velocities, and the shape is consistent with it being a trace through the LVOT aortic valve. So it's not, we haven't captured a mitral regurgitation or something. I think this is true. And then the LVOT VTI is 16, so with a dimensionless index of 0.28, and so I don't think I believe that aortic valve area that it's given us. I think that's from the flow acceleration that we've talked about. I think if we were to trace it in planimetry, it wouldn't be 1.2 centimeters squared. I think this is probably just been using continuity equation and that increased velocity from what I suspect is a supravalvular problem. And again, so the dimensionless index is not going to be used to grade severity.
Interesting, Rob. What do you we'll come back to that. What do you think of this one? What's this?
This is not PEDOF, but maybe it's a PEDOF probe, that we've used here at the right sternal edge. And so that's shown us a maximum velocity of 3.6, so it's still high, with a mean gradient of 25. So that would be in the sort of in the mild range of if it were aortic stenosis, but dimensionless index of 0.24. And so that would be putting it in the severe if we were using it to grade a stenotic aortic valve. Again, I've seen the aortic valve opening in 2D in the short axis view, which was not suggestive of significant aortic valve restriction in motion. So it's not in keeping.
Okay. How would you grade severity of this aortic valve stenosis? What do you think? What do you think the severity is?
So the LVOT, so using the dimensionless index, then that would be sort of, if we were using the maximum velocity from the right sternal edge, that would be in the severe range. But like I said, I'm not convinced based on the 2D imaging that you showed me in the short axis that there was significant restriction.
Yeah. So Rob, if let's ignore this one, and let's ignore the PEDOF numbers, but just based on this and this, and then what you've seen, how would you grade severity if you were needing, like calling a cardiologist, telling them about this aortic? Tell me how you'd describe the aortic valve to me if you were giving me a call about it.
Yeah, so I'd say that the aortic valve is bicuspid, and it appears to be a true bicuspid aortic valve with no evidence of a raphe. So that's how it appears structurally.
Nice.
On 2D, there didn't appear to be significant restriction to motion, but on Doppler assessment, our values are giving us a moderate aortic stenosis.
Nice, Rob. I think we'll end it there. Anything else you would want to look at in this lady?
So with bicuspid aortic valve, we have to be concerned about aortopathy. So in particular, looking at the aortic root and then assessing to see if there's any coarctation. So 50% of patients with coarctation will have bicuspid aortic valve. That doesn't go the other way around though. Yeah. So we just have to look for that.
Yeah. Now, just remind me, what are the cutoffs for mild, moderate, severe AS in terms of velocity, gradients, and DSIs?
Yeah, so
an aortic valve area. Yeah.
So more than 4 meters per second velocity is severe. A more than 40 mean gradient is severe. And what was the other one? And 1 centimeter squared, less than 1 centimeter squared, or indexed less than 0.8 is severe. And then moderate is a mean gradient greater than 30, and I think a maximum velocity greater than 3. And then I have to double check the area, sorry, Emma. And then in terms of dimensionless index, less than 0.25 is severe, and between 0.25 and 0.5 is moderate.
Yeah, nice, Rob. So can we, I thought you were doing excellently. Up until we got, so let's just go through it a little bit. So I think you got everything here, and it was lovely to see that you were like, that aortic valve looks weird as hell. And like, it could just be like a really abnormal cut, but like, given the clinical context and the B lines everywhere and the fact that the LV looks all right, you're like, what is going on with that aortic valve? The LV does look slightly hypertrophy, doesn't it? I know that can happen, obviously, in pregnancy. You get that eccentric remodeling. You increase your LV mass by about 30%. don't know about you guys, but like pregnancy changes in the heart like fascinate me. It's like it's amazing, but maybe it is a little bit chunkier than you would expect. But like it's hard to say. The thing. So what we can see here is like eccentric mild, looks like eccentric mild aortic regurgitation. You described that beautifully, but then you did need some prompting for the flow acceleration, you know, and it is, as you say, it is in the aortic root, isn't it? So it is supravalvular. So it's right that you start to think about supravalvular causes, but then as we get to this is not super helpful, but what I was trying to demonstrate, but it doesn't show it very nicely, is what would you see classically? How would you describe that with a bicuspid aortic valve? If it was showing it in the textbooks and stuff.
So it's sort of asymmetrically opening is how I'd describe it, but I don't know if that's the right way to describe it.
Yeah, so they have this eccentric closure line.
Right.
Is how you, so rather than the closure, you'd see, oh, I haven't got my.
I can see your cursor.
Oh, can you? I can't see it. Rosie, can you see my cursor?
No. Oh, let's
see.
Yeah, we can see your cursor, Emma.
Can you? I can't see it. It's not on our screen. I'm pleased I've got Rosie here as my witness, like for this not just being me. Anyway, I can't find my cursor. But anyway, normally you'd have the line in the middle, right, where they come back together, and it'd be equidistant, like your aortic valve opens and then your line would be sort of in the middle, then it would open again and your line would still sort of be in the middle.
Yeah.
But with a bicuspid aortic valve, that line is eccentric, i.e. it's not quite in the middle. So it's off to one side. And it's really these, and this is a true bicuspid, as you said, so Sivers type 0, like no Raphe. But it's really, and I think you said everything right about, you know, normal biventricular systolic function. Doesn't seem like she's got raised left atrial pressures. Probably those AE primes are a little bit lower than you might expect. They do tend to drop a little bit, especially towards the end of pregnancy, where your SVR, obviously it's dropping throughout the whole of pregnancy. It does start to increase a little bit towards the end, and your E primes can fall ever so slightly. There's quite a mixed literature on that though, and everyone behaves slightly differently. But I just wonder whether she has got slightly delayed relaxation for what you would expect in someone that's this young, probably because she's got chronic, so moderate aortic stenosis or some degree of aortic stenosis. And that all sort of is in keeping, and the S-wave predominance is in keeping with her not having raised LAP. So that was all fine. But then we get to this part, and I think it's probably, Rob, how many bicuspid aortic valves have you assessed?
Oh, not that many.
Yeah, so they tend to have this, you know, because of the opening of the bicuspid valve is obviously very different to your usual triangular opening of a normal valve, and so they do get all, you know, very different sort of, when you look at the 4D flow through bicuspid valves, it tends to be quite chaotic, and obviously they get vortices forming in different ways to what a normal aortic stenosis would be like. And so it's not unusual to see, you know, different flow acceleration profiles through a bicuspid valve. And it's a little bit like mitral stenosis, rheumatic mitral stenosis, even though you see that sometimes in mitral stenosis, in the short axis view of the mitral stenosis, right, you see like a mitral valve that's opening well, but it's actually that funnel shape that causes, it's like the narrowest point in it that causes the stenosis. So you were saying that it looks like it's opening well on the 2D, but it's still stenotic because you're probably not catching it at its most, you know, stenotic point. So you're still getting a significant stenosis through that valve, probably because you're not cutting it the right place. So yeah, so the supravalvular thing, I think threw you off a little bit, but the flow acceleration is really at the orifice of this, you know, bicuspid shaped valve, which you can see sort of the Pisa shell, like there, sort of extending up into all of that. But normally in calcific AS, we would see it forming here, hey, like proximal to the valve, but it does look different in bicuspids. And then coming on to grading of severity, she does fall into the moderate range. The question I had about her, so she's got velocities of 3.1, mean gradients 23, her DSI is 0.28. the aortic valve area by the continuity equation is 1.2, which would put her again in the moderate category between 1 and 1.5. The question I would like to hear you ask about that is, what was the LVOT VTI diameter? So basically, to be sure that, and so in pregnant patients, the gradients and the velocities are less helpful to grade severity because their preload status has changed, their afterload status has changed, and their flow dynamics are completely different. So we do rely more on aortic valve area and DSI when you're pregnant, right? Because your flow changes. But it's interesting that she is in her 3rd trimester and her VTI is 16.
Yeah, it's low, isn't it?
It's a bit low, isn't it? That was concerning to me and she does have B lines and things in her chest. And is she starting to develop some, like, is her LV starting to struggle a little bit? She's not terribly, so tachycardia is a bad sign in aortic stenosis when you're pregnant. If you got a heart rate more than 100, that's a big red flag. She wasn't tachycardic, but I would have expected her VTI to be higher. And so I wondered, could this be almost like a paradoxical low flow, low gradient? Because she's got a normal EF, but her stroke volume index, if we think about, because that's a key parameter to look at, isn't it? 34, it's slightly less than 34. So she's almost on the cusp of being a low flow. Can you see that there? I haven't got my pointer. Yeah, she's almost on the cusp of being a low flow, low gradient AS as well, which is then the DSI to me is really helpful. It does put her in the moderate category, providing that you're happy with your angles and everything. For your aortic valve VTI and your LVOT VTI, which are not too bad here, I don't think. The aortic valve area, of course, you need to then interrogate what your LVOT diameter measurement was, and I purposely didn't give you that, but it was appropriate to calculate that. So the aortic valve area, from the continuity equation probably is relatively accurate. I mean, you could argue it's maybe millimeters out, but she does have moderate aortic valve stenosis. That there is concordance between the DSI and the aortic valve area, as you would expect. And the DSI is obviously in the aortic valve area is relatively flow independent, which is why they're more useful. This I put into for you to critique it. So we absolutely need to be hunting for the highest gradient, and if we don't move beyond the apical window, we'll miss the highest gradient in about 20% of patients. So it's really important that you or the sonographers are doing that. And they reported it as severe aortic stenosis with that DVI of 0.24, just below that 0.25 threshold. But I didn't trust that aortic valve VTI or the Vmax because it's fuzzy. It's not traced particularly well, and I think it was slightly overestimated. So I ignored the PDOF information and actually went with what I thought was the most reliable, which is velocity of about 3.1. But so it all kind of fit with it being moderate aortic stenosis, and they are bringing forward her delivery actually. Based on her clinical symptoms. So she's actually developing a few features of heart failure. Anyway.
No, thanks, Emma. That's a great case.
Yeah, good job, Rob. I think with prompting, you would have got through that okay. I think it's just a case of seeing more bicuspid valves and knowing how they can look. And they all do look a little bit different because that was a true bicuspid. You might have different flow patterns where you've got right and left coronary fusion and all of that. So yeah, the flow profile with colour Doppler does look different in all of them. And you're well done for saying about the aortopathy. She does have a dilated aorta, this lady. She doesn't have coarctation, but those are absolutely things that you need to be monitoring as well in these patients because they're at risk of dissection. Super important to look for those things. Guys, we have a volunteer for this one.
Hey Emma, Zoe here. I can have a go.
Nice one, Zoe. Hi there. Okay, go for it. Hey.
Got a 30-year-old G4P1, 25 weeks pregnant with history of Hashimoto's disease and asthma. Shortness of breath for 2 weeks, 20 meters exercise tolerance, worsening, no chest pain, peripheral edema, and sats on 92% on room air. I've got a focused parasternal long axis view here. The patient is tachycardic. They've got preserved LV function. There is normal contractility to the anteroseptal and infralateral basal and mid segment. There is normal size left atrium and aortic root, and the RVOT appears to be mildly dilated compared to the rest of the chambers, but I'd like to see it in a different view just to confirm that. We've got some short axis view, one in the mid-pipe and one in the wraparound view. Focusing on the mid-pipe first. Oh, sorry, there was also some B lines in the other picture that I could see. Focusing on the mid-pipe, there is abnormal septal motion here. There is a widened QRS complex. There may potentially be some bundle branch block. I'm also worried about a septal flattening, which is happening in systole. I think it's happening at more in systole than it is in diastole. I think that's nice and circular in diastole. I think there's some septal flattening happening in systole, which is in keeping with pressure loading. And there are again some B lines in the far field as well. The visual ejection fraction of the LV here is somewhere around probably 50 to 60%. There in the wraparound view, sorry, I'm just also on clinically. In the wraparound view, there's a dilated right ventricle, dilated right atrium. There's normal structurally, sorry, the tricuspid valve appears to be structurally normal, but I'd be worried about some functional TR here given the coaptation distance. The intraatrial septum is not particularly well visualized here, but wouldn't be surprised if it's bowing towards the left. The aortic valve is tricuspid and there's no significant thickening. It appears to be opening well and not seeing the pulmonary valve very well here. Four chamber view, the RV is severely dilated. The RV base is wider than the LV base. The RV is forming the apex. In the setting of the appearance of this RV, as well as some pressure loading, I'd be worried about an acute pulmonary embolus. The definition around the apex is not particularly well, but I'm getting the impression of a hyperdynamic RV apex, which would be in keeping with the McConnell sign. The tricuspid regurgitation appears to be severe with a wide vena contracta. The jet area also covers majority of the right atrium. And the overall RV function, I'd say that's moderate to severely impaired with impaired both longitudinal and radial contraction. And I think you're showing me some hepatic flow, hepatic vein Doppler flow here. It is showing some systolic blunting, and that's in keeping with elevated right atrial pressure.
Does that change the grading of TR that you just gave it there, Zoe?
There is no flow reversal here. The color flows appropriate baseline, appropriate scale. I still think it looks severe, but I'm not sure why there's no systolic flow reversal in the hepatic vein. Some biplane here. It's showing a volume of 62 mils, which is on the lower side. The ejection fraction is 49%. That's lower than what I would expect for a young patient during pregnancy. The aortic valve, sorry, LVOT VTI is 12.8. That's reduced. Again, that's lower than what I would expect. I'm wondering if there is impaired LV forward flow due to severe RV failure. Got a RV inflow view here, okay, with an eccentric jet of TR, which does have a pizza zone. It is an eccentric jet. I think there is also a functional component to it, looking at the coaptation distance. The TR jet is relatively well filled, although it is not as dense as forward flow. The peak gradient is 45, and the IVC is small. This is so confusing. There is respiratory variation and is not massively distended. Putting this all together, the estimated RVSP is going to be somewhere around 55. It still puts her probably in the severe pulmonary hypertension category, although about the severity of the TR, now I'm wondering if it's moderate. Although, no, sorry, I take that back. I think it's still severe because the RV is impaired. So for the RV function is impaired. So for it to generate this amount of pressure, I think it would be severe TR.
What's this structure where I'm pointing to? I got my pointer back.
So that is, I think that is a prominent eustachian valve. So having a look at the pulmonary valve here, there is at least mild pulmonary regurgitation. The the RVOT is low, in keeping with severely impaired RV systolic dysfunction. In terms of the profile of the RVOT trace, I like to measure the pulmonary acceleration time. There is no obvious.
80.
Oh, sorry.
Sorry.
Oh, it is 80. Yeah, no, sorry, you're right. So that's reduced. That's in keeping with elevated pulmonary vascular resistance. From the profile of the RVOT trace itself, there's no obvious mid-systolic notching from what I can see here. And for the PR jet, we've measured the, I think that's the mean PA pressure at around 21. So again, that's in keeping with moderate to severe pulmonary hypertension.
Okay, so do you want to summarize your findings? Yeah.
Summarize the findings here. I think there is biventricular systolic dysfunction, etiology of which is acute severe RV failure, which is likely due to an acute PE in the pregnant patient. The RV failure has impaired LV forward flow, and as a result of RV dilatation, there is severe tricuspid regurgitation and pulmonary hypertension. In terms of management strategy, this patient is currently symptomatic of heart failure symptoms. Depending on their current hemodynamics, I certainly wouldn't commit her down the thrombolysis pathway just yet, but especially she's in trimester 2, I believe, and that makes her management pretty tricky. So I consider I have a multidisciplinary meeting. I consider her for some hyperinfusion for easily titratable anticoagulation if P is confirmed. I'd have her on therapy to reduce pulmonary pressure, which would include things like sildenafil versus inhaled nitric, depending on how she's supported from a respiratory function point of view. And I would consider this patient for some inotropy, and that's most likely in the form of mirinone.
Nice, Zoe. Good job. Or maybe I'll just go through it. Does anyone have anything else to add about this case? Any of the images? It's always hard, isn't it, when someone asks you that question? Like, I didn't want to answer anything last week during the cases. So I thought you did well there, Zoe. I think there's a few things where you possibly did 2 and 2 equals 6, like, just jump forward a little bit. But I think your overall, though, it was very well done. So I'll just go through a little bit about maybe what I mean about that. So I agree with what you said about this. The LV function looks normal. There's definitely paradoxical septal motion that you can see in this view, isn't there? So and the RVOT looks big. So you're already thinking, all right, someone with peripheral edema, short of breath, reduced exercise tolerance, background of like autoimmune disease, hypoxic. Could there be some pulmonary hypertension going on? She's tachycardic as well, which is a bad sign. Absolutely, RV pressure and volume overload. The RA does look a little bit big in that view. It's obviously hard to quantify that, isn't it, in this kind of view, but I agree with you, it does look on the larger side. Structurally, the tricuspid valve looks unremarkable. The rest of it does. I think these views are not very good. They're quite foreshortened, and it wouldn't be unreasonable for you to say that, Zoe, because you know how we can massively overcall RV size. When they're short, see how it looks like a football and not like a rugby ball shape. That's for UK people, actually. It's probably the opposite here. Anyway, it looks too spherical. So it probably is a bit foreshortened. I didn't put the non-foreshortened images on, which still shows severe RV dilatation. I agree with you about the tricuspid regurgitation. Probably would hang. So the color, there's a proximal flow convergence. Probably if we slowed it down and did a vena contracta, it would be maybe more than 0.7. It is hitting the back wall. However, there's a couple of things going against it being severe. So the lack of hepatic vein systolic flow reversal. And also there's not that sort of dense V cutoff sign as well. And then in this view, it looks moderate. So I'd probably, if I had to choose and someone was forcing me to say moderate or severe, I'd probably say moderate. But I might hedge my bets and say mod severe until you give me more information, like I've got all of the values to glue together. So a word of caution. Yeah, so you were right about the TRV max 45 and probably about 8 from the IVC. She's spontaneous breathing. But the IVC isn't always helpful in pregnant patients because they have increased blood volume. They have caval dilatation. A lot of them have caval dilatation. The completely normal outpatients come in with like 2.5 plethoric IVCs. So they're actually quite unhelpful, sort of when they are like that. Hers is a little bit collapsing, which is maybe a bit more helpful, but you have got systolic diastolic flow predominance in your hepatic vein, and the filling fraction is probably less than 55% hepatic vein filling fraction, which suggests a raised right atrial pressure. There's other things that you could try and look at for that, I suppose. I guess in pregnancy, it's a little bit tricky. So you can look at the position of the intraatrial septum. Maybe it is slightly bowing across to the left. You could look at obviously the filling fraction in your hepatic veins. The IV size and collapsibility can be helpful, but if it's not collapsing, it's not terribly helpful. You can look at, this is in like non-pregnant patients for right atrial pressure estimation. This is all in the new ASC right heart and pulmonary hypertension guidelines. But you can look at, I forget, like your E to E prime on the right side. I think more than 7 can suggest raised right atrial pressure. And then the E to A, I think, of more than 1.5 on the right side. These can all sort of come together if you've got an equivocal right atrial pressure estimation to point you can either upgrade them to sort of 15 or downgrade them to 3, depending on whether these things are present. So I agree, right atrial pressure estimation is difficult here, but it probably is a bit elevated. The biplane is terrible, right? Because your endocardial border definition of your LV is not great. It's foreshortened. And I didn't show you all of it, but it's I should have shown you the 2-chamber, and you could have made a bit more of a call. But the diastolic lengths were out. You can see the tracing. It's a little bit like guesswork, isn't it? So yes, look at the ejection fraction, look at Simpson's, but always critique it. And if it's not good, it's not good. Like rubbish in equals rubbish out. So trust your, sometimes all you've got is your eyeball assessment. And this is not an LV problem, this case, is it? It's all about the RV and pulmonary circulation. So her LV's not too bad. And I agree with you. I think the VTI is down because she's got right heart failure. But yeah, the LV's probably just been squashed, got impaired filling because the RV is just taking over the show. Mild PR. Accel time's a bit low, but remember she's very tachycardic, so it's actually not validated outside the heart rates between 60 and 90. But it's the trend and it's putting it all together. She probably does have some, an element of raised pulmonary vascular resistance. It's not looking like it's a left heart problem. So therefore, all of your other causes, apart from left heart disease, do have a precapillary pulmonary hypertension element. So she probably has got a precapillary chronic pulmonary hypertension going on for whatever that reason might be. It could be group 1, an idiopathic pulmonary arterial hypertension. She might have a PE, she might have CTEPH, she could have potential lung disease, there's a bit of bladder. So we don't know what the cause of her precapillary pulmonary hypertension is. It doesn't seem to be obviously left heart disease. She hasn't got, I don't think I've shown you, but she hasn't got bad MR. She hasn't got a terrible, left ventricle, either with systolic or diastolic function. She hasn't got an abnormal aortic valve. So it's likely to be one of your other groups of pulmonary hypertension, which are all precapillary. The RVOT VTI is down, but remember she is tachycardic. So obviously they tend to go hand in hand. So if you're tachycardic, you will put your VTIs down. But yeah, normal is sort of above 18 in the guidelines. So yeah, it is, even for the tachycardia, it is more reduced, and that's in keeping with reduced RV function. You've got a mean of around, it's not perfect again. So if you see a terrible measurement in the exam, call it out and just say it's I wouldn't trust that measurement. It's not filled out. I can't actually see where the early diastolic velocity is. I'm not sure I would necessarily trust that, but it's coming out at 20, and then you've got to add on your right atrial pressure to that, right? So maybe she's got a mean of about 35 if you say right atrial pressure is 15, or 28 if you say it's 8. So either way it's elevated, but you did then say that, so in keeping with severe pulmonary hypertension, which it isn't. Right. And even so, if we're purely using pressures to guide severity of pulmonary hypertension, more than 75, is it more than 70 or 75? I think 70 is severe. So she's not hitting that category, is she? That's how when you're using pressures, that's what you use to do mild, moderate, severe. So more than 70 would be severe. So she's not in that severe category, but she's certainly got morphological features of significant pulmonary hypertension that needs further investigation. So the way that I would probably summarize this case is say, highly abnormal TTE with morphological features in keeping with significant pulmonary hypertension, potential for pulmonary pressures estimated today at about 55 to 60 millimeters of mercury, however, could be underestimated in the context of RV dysfunction and at least moderate tricuspid regurgitation. There is severe, can't really tell from these, but the measurements of the RV and the other non-foreshortened images show severely dilated RV with moderately impaired function. And then and so, features in keeping with a precapillary element, with the shortened accel time, suggest expert MDT input, because the guidelines do recommend in select cases that, there is risk involved, of course, but she went on to have a right heart cath at a specialized center and had her workup, because this is disaster, right? If you've got, and you see in the stem, she'd had miscarriages, so G4 on P1. Because she's got chronic pulmonary hypertension, this girl, and I'm not actually sure what her right heart cath demonstrated precapillary pulmonary hypertension, but I'm not sure of the etiology. I'm not sure whether she ended up being like an idiopathic pulmonary arterial hypertension or not. I'm not sure. But yeah, these are super high risk patient group. Obviously, even with advances in therapy, they're in that like WHO risk group 4, which is like the most terrible, most like highest event. So between like a 40 and 100% chance of a maternal cardiac event in these groups, with precapillary or pulmonary arterial hypertension. As I say, like a third of them will die even despite advances in therapy. The fetus is at risk because of especially if they're if they've got low saturations, they've got a reduced cardiac output, which this lady absolutely has. And you just need specialist input like straight away, because it's all, you know, very much specialized in terms of what they might start and what can be teratogenic and things like that. They're even more risky during the delivery and postpartum. Postpartum is a really, really high risk period as well. If you get them through the delivery, then that's still a worrying period. You tend to avoid GA with them. So all of those things to protect the RV really. But yeah, she just needs to go to somewhere where they look after these more regularly. And the guidelines actually recommend avoidance of pregnancy if you've got pulmonary arterial hypertension. And it's quite a sensitive topic, isn't it? But they recommend counselling for potential considering of termination of pregnancy. And that'll obviously depend on so many factors. But yeah, it's very, very sad. That's the end of the session, and I didn't go to overtime. All right, thanks very much, everyone.
Thanks, Emma.
See
That
you
was
next
great.
time.
Thank
Bye.
you, Emma.